Hello, I'm Dr. Stephanie Valente from the Cleveland Clinic, going to be talking to you today about breast cancer for the National Surgery Board Review. The objectives of this talk, there are two parts to this talk. So we're first going to review the development of breast cancer and then go over treatment options for both ductal carcinoma in situ as well as invasive breast cancer, review management of axillary lymph nodes, surgical anatomy, and then part two will focus on systemic therapy for treating breast cancer, radiation therapy, and some other tidbits, followed by some questions. So the development of breast cancer, this is the million-dollar question. What causes breast cancer? We know that our breast gland is made up of ducts and lobules. And so on the left side of the screen, you see a cross-section of a normal cut duct. And in simplified terms, every month, just like our skin and our hair cells regenerate, new cells grow inside our milk duct. And that process is called usual hyperplasia. And that process goes back and forth. What we think happens is that for whatever reason, the cells that are normally programmed to die don't die. And so you start to get an overgrowth of cells inside the milk duct, and that's called atypical ductal hyperplasia. Eventually, these cells stick around long enough, and they actually can turn into ductal carcinoma in situ, which is cancer cells that are inside the basement membrane of the milk duct. And eventually these cells get smart and they learn how to grow outside of the milk duct into the breast tissue around it. And that's where you get invasive cancer. Invasive cancer for breast cancer does not spread to the contralateral breast, rather it spreads to the lymph nodes. The lymph nodes act as the trash cans in the body, and they essentially filter blood, infection, and cancer. And if it's abnormal, the goal of the lymph node is to contain it. And so that's why we see swelling with breast cancer if it's involving the lymph nodes, because they're full. So there's two ways to diagnose an abnormal mammogram or calcifications. One is to perform an ultrasound guided biopsy, and that's for a mass, or you could perform a stereotactic guided biopsy, and that's for an abnormality seen on mammograms, such as an asymmetry or calcifications. Regardless of how the diagnosis of breast cancer is diagnosed, a core biopsy should be performed as the initial surgical intervention. And on the boards, it is not an excisional biopsy. It is a core biopsy because it's the least invasive. And with a core biopsy, a clip must be placed because we want to be accurate and precise in our diagnosis of breast cancer. And so these are national guidelines. Once a core biopsy is performed that says whether or not the cancer is benign, whether or not it is cancer or a benign lesion or pre-malignant, the core biopsy can give us information on whether or not it's ductal carcinoma in situ versus invasive breast cancer. Additionally, on that core needle biopsy, the pathologists are able to run for receptors, which are kind of the signaling pathways for breast cancer. So how I think of it, on the left hand of the screen, the circle is a normal breast cell, and it normally has the estrogen and progesterone receptor on that cell. So if we look at a cancer cell, we say, does that cancer cell look like a breast cell, or has it started to mutate or change? So the three receptors that we test for breast cancer are the estrogen receptor, or ER, progesterone receptor, or PR, and the HER2 receptor. So on a breast cell, estrogen and progesterone receptors are found, but not the HER2 receptor. So if you have a breast cancer cell that is ER/PR positive and HER2 negative, that's similar receptor type to a regular breast cell, whereas a triple negative breast cancer means that that breast cancer is growing without the response or without the need for hormones. And estrogen mainly. And so that can become potentially that's the more aggressive breast cancer, whereas a cancer that has a HER2 receptor essentially is acquiring a receptor that normally breast cells don't have. So, and acquiring a signal pathway. So as we talk through this, just understand that an ER/PR positive, HER2 negative breast cancer is the most common, but it's the least aggressive. Whereas a triple negative breast cancer or a HER2 positive breast cancer has a little bit more of a higher risk profile. Now, in ductal carcinoma in situ, we do not test for the HER2 receptor. For DCIS, because it's not invasive, we only test for the estrogen and the progesterone receptor. So what is ductal carcinoma in situ? Again, kind of looking back at that picture, it's breast cancer that really hasn't learned how to invade the basement membrane. You can get calcifications that are associated with ductal carcinoma in situ. And so on the mammogram, you'll see branching calcifications on the mammogram. Any kind of cluster of more than 5 calcifications that are new need a biopsy. And if ductal carcinoma in situ is diagnosed, the T stage is TIS for in situ, and it is a stage 0 breast cancer. How do we treat DCIS? Well, from a surgical standpoint, we treat DCIS similar to invasive ductal cancer, where patients get the option for a lumpectomy or a mastectomy. And I'll go into that in a little bit more detail. So if a patient undergoes a lumpectomy, the goal for surgical margins is to obtain a 2 millimeter circumferential clear margin to ensure that no ductal carcinoma in situ remains in that patient's breast. Traditionally, a lumpectomy for DCIS is followed by radiation, and because it's not invasive, no sentinel lymph node biopsy is indicated. You can also, regardless of the size, a patient can pick a mastectomy for DCIS. And if a mastectomy is performed, the risk of an upgrade to an invasive cancer for removing the entirety of DCIS is about 30%. So a sentinel lymph node biopsy is indicated for a mastectomy because if you remove a breast, you essentially remove the drainage pattern for the sentinel node. So you want to perform the sentinel node biopsy with an intact breast. So that would be performed at the time of the mastectomy. And then if the final therapy is just ductal carcinoma in situ, the patient would get adjuvant, anti-hormonal, or endocrine therapy. So at the bottom of the screen, this is per NCCN guidelines. And for breast cancer, we really follow NCCN guidelines. So as you study for your test, I've put the key NCCN guidelines in there, but this is great just in practice and for studying for the exam to really review these, because anything that's in the NCCN guidelines essentially is opportunity to be asked on an exam. So DCIS, breast conserving surgery versus mastectomy. Switching over to invasive ductal cancer, again, similar workup, history and exam, MRIs for DCIS or invasive cancer are based on a lot of different factors and their considerations. I think the biggest consideration for an MRI is dense breast tissue. So if you're looking at a mammogram and it's really difficult to tell where, the cancer starts and stops because of the dense breast tissue, an MRI could be helpful, especially with lobular cancer. Invasive cancer is a little bit different because we really kind of flipped it a little bit, and all invasive cancer went to surgery first, and then the recommendations for chemotherapy were based off of the surgical pathology. And now really the indications for surgery first versus chemotherapy first are based on tumor biology and stage. So if a patient is an early stage breast cancer and her lymph nodes are negative, then the recommendation is and her tumor biology is estrogen receptor positive, progesterone receptor positive, HER2 negative, then the recommendation is to proceed with surgery first. So we'll go over that and then we'll come back. So invasive ductal cancer, about